Hi, everybody. Welcome back after a summer. I hope everyone had a good summer. For those that were having a summer holiday, welcome to PsyTech's roundtable on Is Ketamine a Psychedelic and Creating a Common Language? And I think we've definitely reached that stage where it's time to have this discussion. Before we do start, I just wanted to quickly mention to everybody that on November 1st and 2nd, PsyTech's going to be holding a masterclass on operations of a ketamine clinic. It's going to be really nuts and bolts. And we're actually going to be offering a 10% discount to attendees. And that is a week earlier than we're going live with the registration page. So feel free to have a look at our website and what's going to be happening there and who our teachers are. I don't want to waste any more time on that. Let's get started. I'm delighted and honored to introduce our moderator for today, Dr. Gita Vaid. She is a board-certified psychiatrist and psychoanalyst practicing ketamine-assisted psychotherapy in New York City. She is a co-founder of the Center for Natural Intelligence, a multidisciplinary laboratory dedicated to psychedelic psychotherapy innovation and clinical practice. She trained as a fellow in clinical psychopharmacology and neurophysiology. Dr. Vaid serves as the Director of Psychedelic Awareness and Consciousness Research at the Chopra Foundation and is on faculty as a lead instructor at the Ketamine Training Center. Thank you so much, Dr. Vaid. I'm going to hand this straight over to you.
Thank you for the introduction, Deborah. I'm very excited to be here with this group of experts, psychedelic experts. And I'm particularly excited because everyone on this roundtable discussion is a psychiatrist, which adds, I think, to the richness to hear how all of these different folks are working with the medicines. I'm going to start off by having each panelist introduce themselves so you can really get a sense of the people we have gathered, the experts. Perhaps you would like to start, Stuart.
Oh, hi. Well, I'm delighted to be here. My name's Stuart Seidman. I'm a New York City-based psychopharmacologist. I focus on treatment-resistant conditions and use all kinds of combinations and cocktails, including ketamine, mostly intranasal ketamine, to get people better. And in my academic career, I did multiple studies using testosterone for treatment-resistant depression in men. I'm also part of a venture capital fund where we invest in psychedelic treatments called Negev Capital.
Welcome, Stuart. Thanks. Julie, would you introduce yourself? Although you probably didn't need much introduction.
Okay, I'll forfeit my time to Ben then. No, just kidding, Ben. I am a psychiatrist and psychopharmacologist. Like Stuart, I have a large private practice at Psychopharm in New York City. My fifth and best and latest book that I just published is called Good Chemistry: The Science of Connection from Soul to Psychedelics. Past couple of decades, I've been a medical monitor for many MAPS, MDMA PTSD studies, and one ill-fated cannabis PTSD study. And most lately, I am a medical advisor, or perhaps even chief medical advisor, to a few different companies. One is a venture capitalist psychedelic investment fund called Palo Santo. Also a cannabis investment fund called CB1, and I'm involved with a group of people who are creating a company called Cardea that will focus mostly on retreats, psychedelic psychotherapy retreats.
Thank you, Julie. Abid?
Hi, everyone. I'm Abid Nazeer. I'm a psychiatrist and board certified in addiction medicine. I'm based out of Chicago. Basically, for the last 5 years, I've been running my two practices of APS ketamine, and just this year we were acquired by Wesana Health. So I'm currently the chief medical officer for Wesana Health as we kind of start a clinic expansion project and a few other things that we're working on. I basically practice mix up. My clinics are based on general psychiatry as well as IV ketamine as my primary ketamine modality. So it's a treatment-resistant, condition-focused psychiatric clinic that really uses ketamine as its primary tool, but multiple other tools as well. And then the other side of what I'm doing in the past has been with in the addiction world, running opioid treatment centers. Yeah, that's pretty much me in a nutshell.
Thank you, Abid. And Ben Sessa?
Hi, my name is Ben Sessa. I am a consultant child and adolescent psychiatrist living and working in Bristol, United Kingdom. I'm Chief Medical Officer at Awakn Life Sciences, which is a biotech company researching, developing and delivering psychedelic medicine for a range of mental health disorders, opening a string of clinics in the UK and Europe. I'm a trained MDMA and psilocybin and ketamine psychotherapist. I've been carrying out psychedelic research for over 15 years, have worked through Imperial College London, administering or receiving various compounds, including LSD, DMT, psilocybin, ketamine, MDMA, and LSD. I'm a writer and a DJ vinyl enthusiast.
Thank you, Ben. So really excited to have everyone gathered here today. And I'm going to start off by opening up the discussion with the controversial question about which is ketamine a psychedelic? And I'd like to turn it over to Julie to perhaps open up what this controversy is about and perhaps explain for the audience what that question entails.
Well, I don't know how controversial it is. I mean, I think it's really sort of splitting hairs. There are lots of different ways to define a drug. One way is that you define the pharmacology and how it works in the brain. And usually you'd lump it in with other classes of drugs, but sometimes you talk about drugs in terms of their effects. So if you're looking at the pharmacology or the chemistry, ketamine really doesn't belong with the classical psychedelics. It belongs with what are called the dissociative anesthetics. Ketamine is used as an anesthetic. It's used in anesthesia and surgery. It is particularly helpful in places where they don't have respirators because you don't lose your drive to breathe the way you do with other anesthetics. In terms of its effect, psychedelic means mind manifesting. So you can see your thoughts, you can see your behaviors, you can get a sort of a bird's eye view of some of the things that are going on. And when you use that definition, then of course ketamine is a psychedelic, cannabis is a psychedelic, MDMA is a psychedelic. So it just depends on whether you're looking at things sort of chemically, medically, or phenomenologically in terms of how it makes you feel subjectively.
Got it. Thank you for that explanation. Perhaps we could have a go around with this panel to talk a little bit about your types of practice, because I'm very struck that everyone has a very different approach to practice. And also perhaps you could comment on, within your way of working, how ketamine fits into your model. Stuart, would you like to start us off?
Sure. And I agree with what Julie just said, but I could add one other point to the distinction between ketamine and other psychedelics is in the outcome. The ketamine treatment for depression lasts about a week, 1 to 2 weeks at most, whereas the studies are looking like the psilocybin and other psychedelic or more traditional psychedelic treatment of depression lasts 3 to 6 months minimum. So outcome might also be a way we can distinguish it. My general practice, I practice garden variety clinical psychopharmacology in New York City, but my focus is on treatment resistant conditions. And so almost everyone who comes to me winds up on multiple medications at all kinds of unusual doses and combinations to get them better. So ketamine is just another medicine as far as I'm concerned. And I'll be very interested to hear others on the panel describe ketamine-assisted psychotherapy, because I don't do any of that. I use ketamine not unlike the way I would use Prozac. I add it to a treatment cocktail and follow outcome and see if it belongs in the roster, in the cocktail or not. And we can talk about the way I give it. I essentially have people come and do the nasal ketamine in my office with me. I check their blood pressure, keep an eye on things, and then I hand them the ketamine and they do the rest of it at home. Every 3 days, they take their dose and then they call me on the phone, we see how they're doing, and they come back and we decide whether it belongs in their cocktail of meds to get them out of whatever we're using it for. it also will be interesting to talk about what we use it for. I find it's terrific for treatment-resistant depression, but it's also phenomenal for anxiety disorders, really phenomenal. I've been very impressed with its utility there. With that, I'll hand it off to the next. I'm very excited to hear what my colleagues here have to say.
How about you, Ben? How do you work with these compounds? What is your model?
So first thing to say is we're just about to open our ketamine clinic. So we haven't yet started using ketamine. When we do open our clinic is very much branded, if you like, as a psychedelic medical center, not a ketamine treatment center. We're only starting with ketamine because that's the only compound that's legally available with psychedelic properties outside of research protocols. But if you like, it'll say Bristol Psychedelic Clinic, ketamine now, MDMA and psilocybin coming soon. So we're not a ketamine clinic. We're a psychedelic clinic that unfortunately is only restricted to ketamine. But this is an important point to make because as a trained MDMA and psilocybin therapist, I will be using ketamine in the same way as I would use psilocybin or MDMA. We are not infusing ketamine with no psychotherapy as an antidepressant and expecting this to be a long-term maintenance model of depression as most ketamine services use it. We will be providing short, intensive, discrete episodes of psychotherapy using ketamine as an adjunct to that psychotherapy in much the same way as we'd use those other compounds, which allows us to do that for a much wider range of indications, not just TRD, but also anxiety disorders, PTSD, eating disorders, depression, and addictions. So, as I said, I wish I could sit here and say we've been doing that for years and it works really well, but we're about to start very soon. But the emphasis being, it's kind of irrelevant that it's going to be ketamine we're using. It could be any of the others, and it will be all of the others as soon as possible.
Thanks, Ben. How about you, Abid?
I think the key to remember is that, I guess my approach is a little bit more overall agnostic in terms of, what is the exact route. Like, I agree with Ben, that ketamine is going to fit kind of just as another tool with the other psychedelics in assisting psychotherapy. And I wouldn't probably say I'm at the end of the spectrum as Stuart is in terms of using ketamine just purely like, it's almost like we use it pharmacologically with other SSRIs or SNRIs, but I fit in the middle. So I feel it depends a lot on the patient. There's so many different subtypes of patients and what kind of experiences they are willing to have, what kind of buy-in do we get, insight level. Some patients just, might not be well suited for psychotherapy during, let's say, an IV infusion. However, we want integrative therapy between the IV infusions, right? So I've been using IV primarily because of the control I get with the med delivery. I mean, we can infuse somebody is up to 90 years old, as low as 11 years old, and we can control the drip rate. We can control how, like the peak curve, like the Tmax, Cmax, we can really adjust that and fine tune it for each person individually, which allows us to help a lot more people. And I would say there are some patients who will do great when they just receive their maintenance ketamine. They've been doing really well on it. They come in. I would disagree that it only lasts a week or two. I know much of the data says that, but to me, what makes it quote unquote last longer, the benefit, and this is the key distinguishing point between there are a lot of ketamine clinics that might not offer much mental health treatment at all. It's just purely med administration. And when you don't have good screening protocols, you're not really addressing the whole condition, encouraging healthy lifestyle, providing psychotherapy services, handling the pharmacological co-management. We do a lot of cognitive testing at baseline and throughout their ketamine course. But when we approach it all, our goal is to give you the least amount of ketamine possible. And I would say most of our patients are maintaining around, somewhere between 4 and 6 weeks. Even a lot of them come even every 2 months. But the more they do for themselves and the more we provide a supportive mental health treatment program for them, the less ketamine you need. And what kind of ketamine? As we go forward in Wesana Health, we're going to be treatment agnostic, IV, low dose lozenge facilitated, psychotherapy that's facilitated with low dose lozenge ketamine, IM ketamine, and then obviously looking forward to psychedelics. So in the end game, how is ketamine a psychedelic? I do think that yes, it is, because our framework has to be consumer or patient facing. What is a language we're going to use for them? And as pharmacologists and physicians, 5-HT2 receptors means nothing to the patient. So it really is going to depend on what kind of verbiage us as a field are going to use together so that we can get more mass adoption of these new medicines.
Thanks, Abid. Julie, could you tell us a little bit about your way of working?
It's, I would echo what most of the other people have said here, and also Abid, that it's not one size fits all and different people need different things. I have referred my patients to get just straight IV treatment. I have referred more of them to get ketamine-assisted psychotherapy. I've referred some people to places like Mind Bloom, where they help the patient and support them by doing it at home. And then I also have some patients who are very familiar with ketamine and its effects and have been in one of these other arenas where I will prescribe just a nasal spray for them to use at home when I check in with them, which is, more like what Stuart is doing. So it really depends on where the person's at and what they're comfortable with, and also honestly what their finances are. I mean, everything, you're more likely to get insurance reimbursement if you do the sort of medical IV route. If at all, and the other forms, there's not going to be much reimbursement. So it does get a little bit pricey. And one thing I would like to say about generic racemic nasal spray ketamine is that it's incredibly cheap. It could cost as little as $70 or $80 for a bottle of nasal spray that can last a patient for months. And it is absolutely the cheapest way to go. And my assumption is over time, it will become more prevalent for that reason. I see Stuart nodding his head.
It's kind of amazing, the cost of Spravato versus the cost of the same exact thing from a pharmacy. Orders of magnitude.
Yeah.
I would say Spravato it cost so much money, I agree. But I will always give Spravato some credit for opening the market up and finally getting a ketamine product approved by the FDA, which takes a lot of time and energy and money. And the fact that it got pushed through and was supported by big pharma, I get it. Makes it ended up branded and way too expensive. It's crazy how much pricey it is compared to just compounded intranasal ketamine. However, for a patient, like depending on their plan, Spravato, we have a lot of patients switch from IV to Spravato when they can't afford IV anymore. But Spravato, they might end up paying $0 or $10 per treatment. Insurance companies covering the rest. So from a patient standpoint, it actually could be the most affordable route.
Thanks, Abid. I'll also add that my way of working in private practice is very much psychedelic-assisted psychotherapy. And being a psychoanalyst, I really focus on the therapeutic process and weave it in to open up the deeper psychedelic experience to use it for therapeutic gain. So we really have a nice mix on the panel of the different approaches. I'm wondering if people...
I wonder if we can ask you to expand on that a little bit.
Well, I'd love to expand on that. What I was going to do, and perhaps that'll start off, is for us to all perhaps come up with a brief clinical vignette that might give us illustrate the ways in which we're working. One example I could offer is when I was first working with an individual who I met with twice, just to give you the sense of the pace of the work. A young woman, a college student, had had terrible experience with 2 rape episodes, had been in a lot of therapy, not with me. After 2 meetings initially, I invited her into a ketamine-assisted psychotherapy session, during which she saw herself and her life as a fabric. And she described in the session feeling like she was a fabric with rich embroidery and stitches. And she saw a stain on one aspect of the fabric, which she said was her rape experiences and questioned in the session, why has that become her center of gravity when there's so much more in the expanse of her life and her being than just that one stain? And it was quite remarkable and beautiful to see her appreciate the richness of her life and her being and how much that experience or those experiences had taken over her life. And subsequently, that shift in terms of the centrality of this trauma was alleviated. She really was able to let it go and expand beyond it. And I think that captures a little bit of the beauty of the work and the process of the work that ketamine and I think all psychedelics offer. Ben, would you like to give us an example of some of the ways in which you work, perhaps with ketamine or some of the other medicines that captures the way in which you work?
As I said, I have not started working clinically with ketamine. So whilst I have personal experience with ketamine in research protocols, including receiving ketamine, I can't talk about a large caseload of ketamine-assisted psychotherapy patients of my own at this stage. But in issue of, is ketamine a psychedelic? I see the similarities between drugs like MDMA, psilocybin, and ketamine as much greater than their differences. Julie is absolutely right in her introduction in terms of the taxonomy of these different compounds, and the classic psychedelics being the partial 2A antagonists, agonists like LSD, psilocybin, DMT, and mescaline. And often people call them just psychedelics with a capital P. I think more accurately, we should call them classic psychedelics because of all those other groups that Julie mentioned, the entactogens, MDMA, etc., dissociative anesthetics, ketamine, including cannabis, including salvia, including ibogaine, and a whole host of other plant medicines. They are all, in my opinion, psychedelic with a small p, if we define the psychedelic experience as an altered state of consciousness. And if we add another layer to this, which is when combined with psychotherapy, when these medicines are taken as part of a course of psychotherapy with non-drug preparation and non-drug integration sessions used as tools, as an adjunct to psychotherapy, then the similarities become even greater. It doesn't really matter which compound is used for what psychiatric indication, in my opinion. When they're combined in a trusting relationship in which a patient feels contained and cared for and held, they all have a similar effect of a peak experience, which allows a patient with rigid, stuck narratives about themselves and the world to be challenged. And of course, they all have different subjective psychological effects reflected by their different neurobiological substrates, but it doesn't really matter, in my opinion. I think in recent years, we've started to fall into pigeonholes with MDMA being directed towards PTSD and psilocybin being directed towards TRD and ketamine being directed towards depression as well. I'm quite certain that 5 or 10 years from now, all psychiatric indications will be treated by all psychedelic drugs. We'll have access to all of them. There'll be a great deal of patient choice. There'll also be combinations of these different drugs within individual treatment protocols. So I think we've got to be careful not to fall into these pigeonholes at this stage and keep our minds open as to what are the similarities between these drugs as opposed to their differences.
In some ways, Ben, you seem to be suggesting that when we're talking about psychedelic, the question is more psychedelic as a process and a different approach, which might even, in some ways, shake up the ways in which we as psychiatrists think about diagnosis as treatment, right? You're talking about more about a psychedelic approach, if I'm understanding.
Yeah. I mean, and forgive me for sounding like a child psychiatrist here, but for me, it all goes back to the attachment relationship. I'm increasingly against the whole concept of categorical diagnosis in psychiatry anyway. They're all the bloody same. Doesn't matter if you hurt and displease, upset and humiliate a child, they will develop a mental health problem of some kind. They're like little fruiting bodies popping up out of the ground where the trauma is the mycelium below. Now, it doesn't matter. Some are going to get eating disorders, some are going to get PTSD, some are going to get depression, some are going to get anxiety, some are going to get personality disorders, many are going to get addictions of something. Doesn't really matter. They're all irrelevant. The bottom line is the underlying mycelium that caused all of them, and any which arbitrary one it is. And what the psychedelics do is they disrupt that rigid narrative of thinking that occurs as a result of that child abuse and maltreatment. And they disrupt it in such a way as, for a few precious, privileged hours in support with a guide, the patient, for the first time in their life, is able to return to that pre-verbal level of functioning before they laid down those rigid narratives that resulted in those mental health disorders. So it doesn't matter which tool we use. The point is the state that they are in, and we call that state a psychedelic state because it's an increased network connectivity, an increased neuroplasticity, an increased flexibility of thinking, which allows you to flatten and level the playing field of all of those competing traumatic narratives. And the patient glimpses this other world for those few brief hours. And with the skill of the therapist and the importance of the non-drug integration sessions, they then use that as a platform with which to rebuild, reboot, defrag, rebrand their lifestyle and overcome those diagnoses which are artificial labels anyway, and regain better functioning.
Okay, that's pretty much a mic drop, Ben. So, we're done. We're done here. We could just wrap up early.
Well said.
Very well said. I just want to. Exactly.
I'm sorry.
Julie taught me everything I know.
Yeah. Thanks, Ben. That's sweet. So I want to jump in here because there's a few things that my impulse control is lagging. So cognitive flexibility is one of the important things that you're bringing out, Ben, that for a few hours, there's another way of thinking, there's another way of feeling, there's another way of being. And if they can tap into that, if they could take that home with them, if you could take notes or write down a couple of things, it's a shift in a framework, it's a shift in a perspective. And I think, you're mentioning that all these different diagnoses, who cares? It all is coming from the same thing. And I think, for the most part, I think that's true. I think there's a few outliers that are very pharmacological and structural, but mostly they have one of the things they have in common, whether it's anxiety, depression, eating disorder, addiction, are these ideas, these sort of rigid beliefs. If I do this, I will feel this way. I feel this way because of this. It's these obsessive, repetitive thoughts. Like I had a patient who was terribly depressed and anxious for years and years and years. And he really had like this running dialogue of, oh, I'm stupid. I can't do anything right. I never win, always going. And it was only with ketamine that he could sort of replace the tape. I'm not that stupid. I'm actually doing okay. But it was a shift from cognitive rigidity to cognitive flexibility. And I think that's why these medicines would work for anorexia and abuse issues and OCD and depression, anxiety, because it comes down to this rigid way of believing or thinking or acting that we're trying to shake up and reform.
I think it's so unique because in some ways, I think what everyone is addressing is how it's such a menu of different approaches that these medicines can offer, from pharmacological relief of symptoms, but also to really going to deeper levels of healing, of changing patterns of thinking, fixed beliefs and ideas. And Ben, you also point out even early wounds and attachment experiences or trauma experiences. It's quite a vast way of working, and also really shakes up the conventional way in which our psychiatrists have been trained to think and work with patients, or at least approach treatment.
Yeah, and forgive me, I am quite blunt in my description of all mental illnesses as the same. I'm not that naive. Obviously, they are all different. They all present differently, and there are trigger points and strengths and weaknesses that would push a certain person towards a certain diagnosis. And it's much more complex than I'm putting in that very blunt analogy earlier. Julie's quite right to point that out. And of course, there are some very neurobiological mental health problems, things like ADHD, which is very much a physical brain disorder, and things like chronic schizophrenia, which falls somewhat outside as well. But generally, the long-term chronic, unremitting anxiety-based disorders are so often associated with this early trauma. And I think the point about trauma that you're making just there, Gita, is when we talk about child abuse, we need to talk about the broader child abuse. Most people think of child abuse and they think of the biggies that hit the social services radar: sexual abuse, physical abuse. Don't take your eye off the ball when it comes to emotional abuse and neglect. That drip, drip, drip effect of, I don't love you, your dad doesn't love you, your sister doesn't love you, we didn't want a girl, we wanted a boy, your artwork is rubbish, you haven't got any friends, you're fat, you're ugly, you're stupid. You know, no one's being physically or sexually abused here, but that kind of drip, drip, drip emotional abuse that can be throughout a person's childhood is profoundly damaging to a person's psyche and their development of self and their narrative of the world. So we have to broaden our understanding about what we know of childhood trauma. Many of my patients, you know, have come through social services and institutions with severe abuse. That's kind of easy to see. But I would say 99% of my patients, when I ask them that question, what was your childhood like? They pretty much all say a bit rubbish. I didn't feel loved. I didn't feel cared for, that sort of thing. And so in broadening our understanding of what is child abuse and what is child maltreatment, you really can assign that diagnosis of trauma, small t trauma, to pretty much every single chronic mental health patient. So few actually sit there and say to me, oh, I had a wonderful childhood with no hiccups. Some do, but those that do have the wonderful childhood with no hiccups, they respond really well to treatment. They're not the ones that become chronic mental health problems. So if they have some later trauma in life, they go to all their appointments, they diligently attend all their psychotherapy, and they do well. And they're probably not the ones that need psychedelics. But it's the treatment resistance that dogs psychiatry so badly, that are the ones where psychedelics are really best targeted towards. And that's a significant number, a good 50%. I mean, different disorders, addictions have 90% treatment resistance. PTSD has 60% treatment resistance. You know, psychiatry is the most appalling outcomes. No other branch of medicine would accept the kind of outcomes we do. We've become these learned, helpless palliative care doctors that just get alongside our patients for life, popping in these daily maintenance drugs to keep the symptoms at bay, but never getting right to the bottom of the cause, which is the trauma, because we misunderstand child abuse at a more subtle level. So there is a role for traditional psychiatry. SSRIs have their place, but we're not a very good profession after 100 years of modern psychiatry. I want to be an orthopedic surgeon. I want to get my patient in, deliver them an intensive, discrete episode of high input service like orthopedic operation. I want to mend them and I want to kick them out and never see them again. That's what the orthopods do. Why can't we do that as psychiatrists? We've lost our ability to do that. We've become learned helpless. We don't use the cure word. We don't think it exists. Well, it does. It can exist. We need good, upfront, intensive pieces of drug-assisted psychotherapy with psychedelics. They're the best, most creative piece of engineering we've had in psychiatry for 100 years, and we're going to use them now.
Thank you, Ben. I'm going to weave in some questions from the panelists. An individual asks, is interested to know how the treatment for resistant OCD by IV infusion differs from resistant major depressive disorders, the difference between treatment for OCD versus major depression by IV infusion. Stuart, could you give us a hand with that question?
I think Abid is probably better able to answer that. Treatment-resistant OCD is really tough. And by the way, just to speak to Ben's point, it's inspirational, everything you've just said, and I hesitate to challenge it in any way. However, it's a hypothesis. Everything you're saying is a hypothesis. It may be true, and I hope it's true. It's certainly hopeful that we can cure our patients in that way. We may see different patients. I treat the sickest of the sick, and sick, bipolar, schizophrenic, treatment-resistant OCD. I wish it were trauma-related. Often it's not. It's hardwiring. It's biologically related, and it may be amenable to psychedelics, but less easy than what you've described. I'll hand off the OCD question because I don't have enough experience with it.
And before I hand it over to Abid, I would say perhaps it does get into what you pointed out, Stuart, a patient selection. A lot of it might really reflect that, because my practice is very much like Ben's, where I think there's a composite of influences that can be opened up very, very beautifully with psychedelics, but it's probably not the same class of patients and family of patients that you were seeing, Stuart.
Right, as if you're reasonably well put together and then you've had these hits on your early life attachment paradigm, psychedelics would be terrific. And of course, there's a lot of hand waving about default mode network, but it works. It really, you know, that network of repetitive, and we've all seen depressives who get stuck in those things.
So back to the question of OCD and major depression, Abid, could you enlighten us?
Yeah, I mean, I agree a lot. I mean, Ben's on a roll to me, seriously, but I agree with a lot, everything he was saying, that he was kind of alluding to how there's commonality amongst, you know, let's say anxiety disorders. I view it kind of like an affective spectrum, an anxiety spectrum, psychotic spectrum, and a cognitive spectrum. And the treatments overlap, the etiology overlaps. Within the anxiety spectrum, you know, PTSD has some unique characteristics and OCD has some unique characteristics. I think OCD is one of the hardest treatment refractory severe OCD. It's one of the hardest conditions to treat, period. We know OCD is more amenable to cognitive behavioral therapy. When we look at where ketamine fits in, I don't think the protocol's there's nothing different in how we're administering it or how we're approaching it dosing wise, really much from maybe a little higher dosing sometimes compared to depression, but it all comes down to really the therapy that's being augmented when we're dealing with OCD. If I'm treating somebody who's purely OCD and does not have an affective disorder like depression, that's super rare. Usually they're comorbid, but when that happens, you know, I think it comes down a lot to the therapy that's happening in between with the neuroplastic state that they're in. You know, are they doing enough, you know, structured CBT more and probably at a higher frequency of therapy throughout the whole process to try to take advantage of that neuroplasticity? I have much lower success rates with OCD. I don't know how the rest of the panel feels, but I mean, it's tougher to make a dent at it. When there's comorbid depression, ketamine can work its magic a lot better, and we do see a lift in overall quality of life. You might see the Y-box scale move kind of, but you'll see the PHQ-9 scale, you know, move significantly. So when you look at the overall, you know, like outcome, I'd say it's positive, but the approach is not much different, except the therapy has to be a lot more focused for OCD. I would say this concept of that, you know, Ben was bringing up about, can we change our outcomes? We have such low general success rates in the field, and the goal is for, you know, the C word, cure, and not have to see a patient again because they're better. Like in our practice, we like to they graduated out of our program. That can happen, but ketamine got us closer to that. But I think, you know, as psychedelics come online, I think that our entire verbiage and our bar has to be set a little differently, because we are shooting for that. We are going to see that a lot more, and outcome-based approach to medical care is important, that we're measuring this. And I think the data will continue to aggregate and show that we're getting a lot, instead of partial response as our bar, we're getting to, like, you know, remission as our bar. So that also brings up the question of, he said, I'd like to be an orthopedic surgeon, right? Like, that's a good analogy. You want to go fix something and the patient gets better and then you move on. But that's also surgery, and which is, you need a specialist to do that, and do that very carefully. So as we're, you know, like if you put somebody under psychedelic influence of any psychedelic or ketamine and not prepare them, not have the right kind of approach to support them, monitor safety, manage expectations, screen appropriately, and really somebody that's skilled at this, you could botch a surgery pretty bad when you really start opening up previous traumas, you know, and there's no prep. So I think it begs the question that what is going to be the, I guess, framework of how we do this once it's a legal and FDA approved option for psychiatrists. But is it something that, what is the certification level you're going to need? Who can do this kind of work? Because I don't think it's as easy as, for somebody to come in who's not familiar with this, not trained, and doesn't have that expertise to open up the brain and do surgery and then basically hope that, they're better. They'll probably have, like chronic knee pain, if we put it back in Ben's orthopedic analogy.
I'm going to go to another question, which you touch on, Abid. Someone asks, when patients take ketamine at home, have you noticed any adverse reactions, or how did you prepare patients to make sure they don't panic at home?
I can handle that one. I 5, 6, 7 years ago when I started doing this, I was quite nervous about it. This was not routinely done. I would get a compounding pharmacy to do it. I don't want to go into the story how I started, but it had to do with a patient who had a dramatic response in a research study and just couldn't get it as an outpatient. And so I got it for her, and then it was so dramatic that I continued doing it. So in the very beginning, I did almost the Spravato model where patients would come in and I'd sit there, I'd check, they do 2 squirts, I'd check blood pressure, I'd wait 15 minutes, do another 2 squirts, wait another 15 minutes, another 2 squirts. I'd keep an eye on them, don't drive, and then years and years, and I'm hundreds of patients into this, it is safer than anything else I prescribe. It is, now I say, do 6 squirts, all right, 4. We start with 4, do 2 more. They dissociate a little bit. They wait in the waiting room with other patients next to them. They do fine. I come out, check on them, give them very careful directions every 3 days. I have them do it at night in bed so they don't walk around or fall or certainly not drive, but they do fine. Everyone does fine. Not one adverse event, not one. It's really quite safe. The FDA was quite concerned with Spravato and put in this REM system to make it only prescribable under these certain circumstances, but they're clearly not necessary. I don't know what the others think about this, but I think Stuart, they're not necessary.
Could I ask you a question? How do you, what's your approach to the concept of tolerance or addiction? The concept of diversion, or the concept of somebody losing their benefit from too frequent dosing? Because I heard you said 3 times a week or something like that with your regimen.
It turns out that ketamine is actually not highly controlled. So you can write 90-day supply with 5 refills. You can give them years supply. The pharmacy I work with gets in touch with me if they get their supply too soon. So yes, they could abuse it by using all of their 90-day supply in a weekend or something like that. I don't think they do, and I don't take ketamine patients on for ketamine. I kind of grow my own. These are all my patients who I know very well over years, who usually have been through MAO inhibitors and all kinds of cocktails until we get to ketamine, including rarely ECT, but sometimes TMS. I really don't prescribe it until they're at the end of the line. And they would not be smart to abuse it because it is life-saving. It is life-saving. And so, it's the same thing with cocaine addicts abusing stimulants who have ADD. They're not smart to abuse their stimulant because then they don't have a treatment for ADD anymore, and ADD treatment saves their life. It's the same thing with these depressives and people with anxiety disorders. They don't abuse it. They really don't. Maybe one slips through here and there, but there's been maybe 1 or 2 where the pharmacy was uncomfortable with the frequency of them getting refills, and so we stopped prescribing. But the vast majority, it's a non-issue.
I do want to add a quick little thing. I would like to say that has also been my experience with my patients, Stuart, is that I'm not really having my patients abuse what I'm giving them. However, I do know that people are abusing ketamine, people are getting addicted to ketamine. And my patients who go to NA meetings are saying that a lot of the new people coming into NA meetings now are coming because of ketamine. And I'm sorry to report this, but it is happening. We do have to consider that it is one of the risks, in the same way that I just want to stir the pot a little and say that one of the risks of ketamine-assisted psychotherapy or psychedelic-assisted psychotherapy is that there may be transgressions that are currently being called therapy abuse. I think we need to come up with a better name. But we know that there have been some transgressions between clinicians and clients in terms of sexual advances or other grossly inappropriate behavior. And I have started thinking, when I think of the risks of psychedelic-assisted therapy, I have started adding that to the potential risks. So just want to throw that out there. One of the earliest alleged cases of misconduct that looks like it wasn't so alleged had to do with ketamine therapy back in the 80s, 70s. So anyway, I just, if we're talking about risks, I think it may be low, but it's not zero. And that is abuse in terms of people getting addicted to ketamine or misusing it, and also potentially improprieties between clinicians and those receiving care.
But that's on our field. We need to police that and make sure it doesn't happen. I hear you, but I don't think we should blame the drugs as much as the
Not
people
blaming the drugs.
prescribing them.
People, it's always a dance between the person and the substance. And sometimes it's a dance between two people and a substance. It's very complicated. And this isn't necessarily the place to, I mean, we could talk about this for hours or even devote a whole conference to this, but as long as we're talking about risks, I just feel obligated to mention it.
Yeah, I would agree with all of that. I mean, in some ways, I don't see that there should be any great distinction between these issues of safety and consent and confidentiality and safeguarding between psychedelics and any other medical intervention. We have the same principles, whatever, but there are extra levels of vigilance and concern with psychedelics in that a patient is in a disinhibited, relatively vulnerable state. But the principles of how we care for our patients are universal. It's certainly arguable that this certainly shouldn't be used as a stick to beat psychedelics and suggest we don't do the research and move forward. Indeed, it's arguable that there's far higher risks of these kinds of abuses occurring in an unregulated underground psychedelic scene.
Absolutely.
Than there is in an overground regulated scene. So
I think we've seen that.
And we've seen that, yeah. So there are extra levels of vigilance required with psychedelics, but the principles of these safeguarding things are things we as doctors do every day for all our patients.
I'm just going to take another question. One question that's been asked is, have you noticed great differences between the effects and the lasting effects of intravenous administration of ketamine versus nasal or lozenges? There's the route of administration.
Yeah. To me, I feel I see definitely differences, but it really depends, because like IV, I tend to always gets me the longest lasting effect. Like just looking at just the way, Spravato got through the FDA with this maintenance regimen of every 2 weeks. Like I said, we have patients anywhere from every 2-3 weeks at minimum, all the way up to every 6-7 months coming in for one maintenance IV treatment. But then if you're going to look at IM ketamine, you're going to, like, what are the odds of having the psychological breakthrough, an ego, death and rebirth, a reframing of self, all that? It's a lot higher likelihood, I think, the higher up, like the more dissociated you are and the more skilled therapists with you, I think you have a higher chance of it. So, I mean, that can give you that kind of lasting effect where you're not coming back that often at all, and you're getting those, like, you can even possibly have 1 or 2 sessions and be okay as your baseline has now lifted from where you were before. Whereas when I get wary. I had posed that question about risk of, like the diversion and abuse. I agree with that. We don't really see very much of this at all with ketamine overall. However, the other part of the question was about dependence, and not so much of a physical dependence, like somebody's, got a withdrawal syndrome and that typical definition. I'm just saying the tolerance, let's call it, probably better route to say is the tolerance to it. So like, I just noticed the more somebody receives ketamine, the more tolerance they get, the benefits seem to wane. So I get wary of somebody maybe doing ketamine multiple times a week, ongoing, chronically. I don't know. That's why we're always measuring cognition in our practice, because like that's one big risk of too much ketamine is cognitive blunting. There's also obviously other risks from that. So I just wonder if some of the you guys see benefits wane from that type of approach of frequent dosing versus, that's why I like with IV, like if somebody's coming in every 2 weeks in our clinic, but they used to come in every month, that to us is a signal or an indicator that we need to increase all other interventions we're doing psychiatrically, right? We'll look at all aspects, combining with deep TMS, data versus increasing the therapy frequency, all of that, or adjusting the pharmacology that they're on, the SSRI or SNRI. So we want to optimize that. So we're doing something to bring that interval back up to at least our goal is around monthly. And if it's more frequent than that, we get concerned. So I've seen patients when they're coming in too frequently that their benefit goes away. Suddenly they're stalling in their progress. So I'll just throw that back to the panelists.
We have a question specifically for Dr. Holland. What are your thoughts about adopting consented audio videos as part of the psychedelic psychotherapy to address the issue around therapy abuse directly?
Well, some of the consent forms that are being used in research are already mentioning this issue of transgressions as a potential problem. It's already in writing, whether it has to be video, I don't know how necessary that is. Not everybody uses consent forms, I guess is one thing I would say. The research model is a very long consent form. And I imagine some of the clinics have consent forms, but I certainly know people who are just doing ketamine-assisted therapy who treat it like regular therapy. You don't typically have a consent form. So I think it's a reasonable idea. I think it's important to talk about consent. Oh, I know what I want to get back to. Ben, you were talking about the holding environment. And then I was sort of joking in my head, like, as long as it's not literally holding. But the truth is that there are people who really benefit from being held. And, before COVID, I definitely had some patients who wanted a hug hello and a hug goodbye. And I was like the only physical contact they got. These people who are like hermits and don't leave the house, or they have schizophrenia, or they have autism, they have no friends or whatever. But like, part of my therapy is that they want a hug and I give them a hug. Not all my patients, nothing sexual. But the point is that we do have to create a holding environment. And there are situations where sometimes there is physical touch, and it is good as, I was going to say unsexy, and that's not the right way, as awkward and uncomfortable and clunky as it might be to list when we have this therapy. Are you okay if I touch your hand, if I touch your shoulder? Do you want to be held? What kind of holding do you want? Like, I think, especially these days, this day and age, and also some of it, like MDMA is a good example, right? MDMA can alter your ability to perceive social cues. You may tend to see some threatening faces as neutral or even more positive than other people see them. You are, one of the things that makes MDMA great is that you're a little less afraid and you can handle some of these traumatic memories. You're more open. So sometimes that means you're more open to being held. And yesterday you didn't want to be held, but now with MDMA you do. So it is important to figure out exactly what the rules are ahead of time, because it's possible that when you're altered, your answers will change. It's incredibly complicated. And like I said, I actually think that we should have a complete conference where we talk about all of this, not as a way to blow down the house of cards that is this process of getting these medicines accepted, but as a way of strengthening the foundation. It's not a house of cards anymore. It's not that delicate. It is time to make sure, that we acknowledge that there's a risk of addiction, that we acknowledge that there's a risk of crazy boundary violations, as there is in regular psychotherapy and also in surgery. You know, I have a patient who was abused by his pediatrician. I have a patient who was abused by her gynecologist. It's not just psychology and psychiatry. Okay, it's happening. We need to talk about it.
And in some ways, you're talking about a new vocabulary of which goes part of this field of talking about what does constitute safe touch and consent and what is comfortable for a person. For one person, a hug might be very intrusive, and another person, it's a life raft. So I think this is another aspect of a new vocabulary, a new approach that needs to be introduced into the work. And then, of course, there's, I think, the issue of psychological addiction to experiences, which I've also seen.
I think it sounds like the field needs practice guidelines, you know, specific practice guidelines that should, we all know in the old days, the therapist would partake also in psychedelics during the therapy, and that is widely considered unethical now. That would be part of the practice guidelines. How much touch is allowed, the rest of it.
It's true that has fallen out of favor. I think there are situations where that still happens. And I would say that we have practice guidelines. It's just that they're maybe not uniformly agreed upon. But I feel like lots of groups have their own practice guidelines and maybe they're publishing them. But I agree, Stuart, that we need something more overt and codified and unified. And at some point, honestly, we're probably going to need some sort of a governing body. Maybe I'm going to take some heat for this, but some sort of group that says like, yes, you're credentialed, you can do this work. And no, you're not really credentialed yet. And here's what you would need to do for us to feel like you are appropriate for doing this work. You know, that is something that we don't completely have yet.
I think that's inevitable. That'll probably going to happen as we bring it into the medical framework. That's going to happen, and I agree, Julie. I think it should happen. Sorry, Ben.
I was just going to say, you know, these practice guidelines are already there. As I said earlier, the same principles apply to psychedelic medicine as apply to all medicine. Putting the patient at the center, the patients writing their own care plans, consent and confidentiality being at the center, safety and safeguarding issues being at the center. If you don't know those things already, they don't need to be put into a code for psychedelic therapists. You shouldn't be a clinician anyway if you're not aware of those kind of basic fundamental principles of patient care. So I do think, but practice guidelines, psychedelic therapists is a really interesting idea, and they kind of do exist. And like Julie said, if you look at any psychedelic protocol for research, they have all this enshrined already, as do clinics. Our own clinic, Awakn Life Sciences, very clear list of FAQs and expectations, and very clear consent form about what we will and won't do, and we allow the patient to lead us on that as well. And especially this issue of touch. You know, body work is a really important component to psychedelic therapy. And it requires careful vigilance of the rules. And like Julie says, setting that up, when you might use it, asking permission, being very clear about what sort of touch you would consider and whether or not the patient consents at the time for that. One of the things we do is before we touch, we'd ask the patient to put out their hands like that to the therapists. And that's a kind of invitation to hold a hand. If we were going to touch and hold hands, before we touch, we would hover over them and say, would you like me to hold your hand? Would you like me to touch your arm? You know, basic rules that actually are not new to psychedelics at all. But, you know, we do have to be vigilant that there are these extra risks. So, and the most important thing, like you said, not allowing these kinds of concerns to derail the most important thing. Let's not miss the wood for the trees, that this is really important work to develop a way going forward.
Well, I think we're close to being out of time. Just a minute to go. Does anyone have any other thoughts they'd like to add before we wrap up? This has been an extraordinary panel. I feel like we could be talking for several more hours. There's so much richness. Thank you, everyone, for contributing.
Hi, everyone. Thank you. Thank you so much, Dr. Vaid, Dr. Holland, Dr. Sessa, Abid and Stuart, Dr. Nazeer, sorry, Dr. Seidman. It really was mind-blowing. The chat was going wild with questions and interest. And I just have to say that all of you, Ben said that there's already a book of how this all goes. And we all thank you because all of you have contributed. You're pioneers in the field and you're all contributing to the language we're going to use, the protocols we're going to use. Obviously, there'll be mistakes in the future, but with leaders like you, we all feel like we're in safe hands for the future of this therapy and treatment. So thank you all for your time today. We really do appreciate it. And we look forward to seeing you all at future webinars and conferences, and thank you to all the attendees and for all your participation today. And we all wish you a wonderful weekend and to be in touch soon. Thank you so much. And just one last reminder that the masterclass is open for registration for all of you guys. It's going to be really interesting and worthwhile. And have a good one, everyone. Thank you.
Thanks.